Good morning. So we'll get started, and I'm going to start talking about pulmonary artery embolisms, of which I know very little, but I learned more after I figured out this talk. But it's clearly an area that we are seeing more of in our institution, and I'll talk about our data towards the end. But it was first identified and described by Dr. Morgagni, who is an Italian anatomist. There are several anatomic issues that he's identified, like the Morgagni hernia and foramen Morgagni and a few others. And he had identified this in these large clots at autopsy, but really had no idea what the physiologic cause was. Fast forward 100 years, and Rudolf Virchow, who is a pathologist, was studying with Jean Cuvier the idea of phlebitis and inflammation and clot formation. And he identified or came up with the idea that these clots were formed remotely and then moved along the blood vessels with their blood flow, causing the idea of embolia or embolism. So he was credited with the concept and the idea of embolisms. He was given all the surgical residents know the idea of Virchow's triad, which is the thought that three areas of blood stasis, hypercoagulability, and endothelial injury are the areas where you get clot formation. But the interesting thing is he actually never came up with that. That was attributed to him post-mortem. In fact, he used to argue with Cuvier the idea of what the role of endothelial injury was in terms of causing clot formation. But nevertheless, somehow it got attributed to him, and it is what it is. Well, fast forward to Friedrich Trendelenburg, and actually the Germans pronounce him Trendelenburg, even though we use Trendelenburg as the term. But Trendelenburg was a surgeon in Germany, and he identified 9 patients of his whom had these acute collapses and went into the laboratory and developed a technique for extracting this in calves. Now, I have no idea how you create embolisms in a calf, then go in and do it. But he developed it. He tried it on 2 patients. Unfortunately, they didn't survive, and he abandoned it. But his student successfully did the first one in March 18th, 1924, and dubbed it the Trendelenburg operation. Now, you have to understand, 1924, we didn't have the heart-lung machine. So he went in there with a beating heart and opened up the PA, extracted this and closed this without going on the heart-lung machine, and the heart-lung machine was invented in the 1950s, and cross-circulation also at the same time. So this was really quite a tour de force. This was presented at a meeting, and Dr. Oshner was there when it was presented, and there was obviously a lot of excitement that this actually could be done. And then during that time, a lot of surgical residents would have all these tools at the bedside of these patients in case this PE would occur, so they could try to extract it. Now, they presented these at these meetings. There were 300 attempts with 10 survivors. And Dr. Oshner was the head of the American Surgical Society at that point and said, hey, listen, we should stop doing this nonsense because we're killing all these people. And he was the first one who really came up with the idea of prophylaxis and preventative therapies, which is the idea of wrapping the legs, ambulation, calf stimulation, and anticoagulation. And he and DeBakey discussed the potential merits of ligating the IVC in select patients to try to minimize this problem. And he was the guy who started the Oshner Clinic down in Louisiana. So thankfully, we're a little bit better than 300 operations with 10 survivors. But the incidence, as you can see, in the US and around the world has actually increased for PEs. Now, DVTs are estimated to be about 100 per 100,000 population, and PEs in 40 to 100 per 100,000 population, with 300,000 deaths in the US. And we'll see that in the US, we probably have more of the risk factors that are associated with development of these issues. Now, interestingly, the case fatality rate has actually dropped throughout the years. And partly because we think that there was the change in practice of how we approach this with anticoagulation and aggressive management, but also because with better imaging, probably the denominator is larger. So we're catching more of the less critically ill pulmonary embolism. So the denominator is larger. That's why we think that the survival is actually improved. So what are the predisposing factors? These are odds ratios. The high risk ones are a lower limb fracture, major trauma, MIs, previous vascular thromboembolic events, and spinal cord injury. Those are the big ones. Moderate risk factors, autoimmune diseases, you can see on the right, inflammatory bowel disease. Cancer is actually interestingly considered a moderate risk. I used to think that it was considered high risk, but metastatic cancer apparently is a higher risk. And then if you look at the weak factors, bed rest, diabetes, hypertension, age, and obesity, I mean, that's what, 80% of the American population? So even though there are lower risk factors, I think the denominator there probably is quite large, so can contribute to an increased incidence in this process. So what's the pathophysiology? Well, people think it's obvious. You have a clot, it blocks up the pulmonary artery, you drop dead. Well, that does happen in a large percentage of the population because you have these massive PEs that totally block the blood flow, but we don't generally see those. Those are out in the community. But we have a cycle that occurs, and it's physiologic, associated with a large clot burden when it hits the pulmonary artery. Now, the physiology of the lung is that it's vasoreactive. So it vasoconstricts in hypoxia. So if you have a partial obstruction and then you have some hypoxia, the body's trying to shunt that blood, but the lungs are trying to shunt it into the areas where it's getting ventilated. And so it increases actually the pulmonary vascular resistance. So you are starting off with increased pulmonary vascular resistance because you have a physical blockage. The RV is not designed to beat against a high pressure. I mean, it's very thin. And so you have this pressure, and then you have hypoxia. So it actually increases the pulmonary vascular resistance regionally because of hypoxia. It's trying to shunt into other areas. So you actually create more of a pulmonary vascular resistance issues, decreased blood flow going through the lungs to the left side, hypotension, more strain on the RV, and it cycles. And so that's how you go down the drain, and then people pass away. Plus, you also have some hormonal issues that are, neurohormonal reaction to the body as well from this, as well as evidence of some myocardial ischemia. So this is the pathophysiology of that kind of the falling down the drain for people who initially survive. Often they present, these are the presentations, syncope, hemoptysis, shock, and acute shortness of breath, sometimes chest pain. But we were taught that pleural chest pain is one of the big ones. But interestingly, the data doesn't bear that out. What are the things that we always have to rule out? Well, the big ones for us are acute coronary syndrome and acute dissection, because these are the other things that'll kill you relatively quickly. And then some of these other diagnoses we are ruling out in the emergency department as well. So what are we looking for? Well, how do they present? Well, often they're a little anxious. Heart rate's high, BP's lower, SATs are usually lower. Don't always have a history of having swelling in the lower extremities, particularly in our patients who are obese. They don't really know that there's a difference when they've had it before. Upper extremity thrombus almost never causes significant PE. Now, there's reasons to anticoagulate for upper extremity thrombus, as it's a marker for having PEs due to lower extremity issues down the road, but upper extremity, as a rule, does not cause significant PEs, nor does have the superficial veins in the lower extremities. They're prognostic for having a subsequent larger PE due to DVTs, but in and of themselves, they don't cause PEs. EKG often shows T-wave versions because of RV strain and other regions for RV strains, such as right bundle branch or whatnot. But the diagnostics that we normally lean on are CT scans and echo. But prior to going through that, we don't use these scaling systems here in the US very much, but in Europe they use a lot, where they basically will see how these people present and risk score to see what the probability is of having a PE, because they don't have as many resources to use and use CT scans as widely as we do. And so this is like Chinese characters, where you have the original version and the simplified versions, because people can't write Chinese characters in the original version. It's too complicated. But if you add up the risk factors, they'll give it a sense of what are the chances of having a PE, and then moving forward with the diagnosis, and that's the scoring system, which I won't really go over. There's a second scoring system, as well, clinical prediction as well, that is also used, and both of them are used widely in Europe to screen as to how to evaluate the next steps in terms of CT scans, EQ scans, and the like. And so what are the tests? Well, in the US, we pretty much use the CT scan because for multiple reasons, very readily available, it's very quick. And if we're looking and don't identify a PE, it can identify other things like potentially aortic pathology, chest wall pathology, and the like. The downsides to it are radiation exposure, even though in relative speaking, it's not terrible compared to what it used to be, 3 to 10 millisieverts. Other studies that have been done are VQ scans, and VQ scans are useful if you're doing specific lung surgery, and I'll leave it at that, but we don't use this as a diagnostic tool in the emergency room for PEs per se. Pulmonary angiography used to be considered the gold standard. We should do them more often, but it's very invasive. It's a lot of radiation. It's also it's not very rapid per se in terms of how we have it built into our systems. And we do miss things. We had a patient that we took care of here about a year ago who had an arrest at home, had return of spontaneous circulation at the scene and then arrested again in the ED. And the thought was whether or not concern was whether or not he had an MI. So with CPR, he was run up to the operating room, thrown on ECMO, cath, which showed no occlusive coronary disease, and then an angiogram was done, which showed occlusion. So from there, we took him straight to the operating room. The problem was when we extracted his clot, he has had acute PEs on chronic, and we did not recognize, we didn't know that because we basically used an angiogram and went straight to the operating room. Had we taken the extra step to go to the CT scan, we may not have taken him straight to the operating room for that because he had some chronic changes in his lungs beforehand. So even though pulmonary angiography is good, we do miss some things with that. And of course, for those who aren't used to looking at CT scans, when we're paying attention to, whoopsie, I'm not going to touch it. So if you look at it, the short axis view, you can identify the ascending aorta, the descending thoracic aorta, and we're really focusing on this in the PAs, which is the main PA, and then the right and left sides coming over here. You can also see the airways down below. And when we're gating the dye, we're really gating it so that we see the pulmonary arteries. So these are scans of our patients. This one is gated, so you actually can see the SVC. Whoopsie. I won't touch the screen. Don't touch. Don't touch. So this one you can see actually it gates. There's enough dye. You see the ascending aorta, descending aorta, SVC, the main PA, and then the thrombus that goes across the main PA going both to the right and to the left sides. In this one, again, it's gated. You can see all of this as well, very well. There's a large thrombus over on the right pulmonary artery. You can see some on the left as well. And this next one, I don't know if I can use the pointer thing. No, it's not working for me. Anyway. So on the next one, you can see this one again is a saddle, involves some on the right. But I don't know if you can see this as well, but you can see it better on this one, where the gating is really, at the PA, you really don't see very much on the aorta and the aorta. There's not much dye in there. And so the gating of this is actually important. If you gate it, you can see all this stuff is great. Sometimes if you can gate it properly and you have no PEs, then you can look for the ascending aorta for dissections and whatnot. But in these, you would miss them because the dye is just not in the right place. So this gives us anatomically where it is. The other is a functional, and which is echo. Hopefully they'll stay moving. But you can see on the right the parasternal long where the LV is underfilled, the RV is really unhappy because it's really overfilled and strained. And over here, there was a clot forming in the IVC, which, let me see if I can get out of this and play it. I knew we were going to have a problem with this one. Here we go. So you can see clearly the RV is distended and unhappy. And on the short axis, this is on this one. I'm sorry, this one, you can see on the short axis, the LV is very small, underfilled. RV is very, very big, really unhappy here. And this is the classic McConnell sign. McConnell sign, which is, this is an apical view where the LV is over here, the RV is over here. And McConnell sign is where the apex of the RV is moving well, but the lateral wall is not moving very well at all on the right side because it's straight. It can't get the blood through the lung. And here is a clot that is in the IVC. You can see her just kind of wiggling around over here. And then on the next slide, this one's a scarier one. So this is a transesophageal echo, and you're seeing the left atrium over here, right atrium over here. Aortic valve is right here in short axis. And this looks like a tadpole swimming through the septum here. But this is a clot in transit where you can see the wiggly part of the clot going through, coming up from the IVC and then going through a patent foraminal valley. So it's moving from the right to the left side. For us, we look at this and we get very nervous that we're going to have embolism. So we just go straight to the operating room with that and try to take this out. What I was going to talk about next is they have, once you have the diagnosis, there is a severity index that is used to give prognostics on how these patients will do within the hospital stay. And the risk factors include, not surprisingly, age, underlying diseases, and specific physiologic presentations, heart rate, et cetera. Some very similar to what the pre-procedure risk was, risk scoring system. Okay, so this is the Pulmonary Embolism Severity Index. It gives you an idea of what the mortality looks like. And if you add up these points, and again, there's a simplified versus a more complicated one, the mortality risk is either low or high, and the high being over 10%. If you add CPR to this, it actually increases it by quite a bit. Now, there's another scoring system where you basically take the severity index and then you add other parameters like hemodynamic instability or a radiographic, echographic evidence of RV strain and failure, and add some predictability within a 30-day mortality as well. And if in the absence of it, of course, most patients do well. And then there's a clinical subclassification of it, besides the physiologic classifications that are used predominantly for research as well as outside the US. What we use in the US more often is the three categories of kind of low, medium versus submassive PE versus massive PE. And these are the two that we really focus on, is submassive and massive, and the differentiators are above. So you generally, on the submassive, the blood pressure is okay, but there is evidence of RV dysfunction either echographically, chemically, or evidence of that electrically. And then if there is myocardial necrosis, of course, with troponins, it gives you an idea these are submassives. And then massives are people who have had continued hemodynamic collapse, requiring more support and profound bradycardia. So how do we treat these? Well, we have the most of the therapeutic options are basically some form of either clot extraction or anticoagulation or thrombolytics. First thing, of course, you always have to resuscitate the patient adequately. This is something that has evolved. A lot of times people have thought about, let's just treat, and then the hemodynamics will improve by treating. The move is really away from that to resuscitate first, get blood pressure. ECMO is becoming a more important role in this therapy, and then add your anticoagulants and thrombolytics at this, kind of concomitantly. So the approach is based on your clot burden size, right? With the location, whether it's central or peripheral, level of hemodynamic stability, and whether or not you can tolerate thrombolytics or not, and what options are available at your own institution. So with thrombolytics, TPA is generally the workhorse. Not many places still use streptokinase or urokinase. Obvious contraindications are off on the right for active bleeding, recent neoplasm, history of hemorrhagic stroke, et cetera. But despite that, the complication rate for this is relatively high. So there's about almost 10% chance of severe bleeding with RTPA, despite the fact that you've ruled out the people based on the high risk and the absolute contraindications with as high as a 2% cerebral hemorrhage. Well, what about catheter-directed? There's several different devices that are out there that are purported to be useful in these patients. The data, unfortunately, is really not great. There's only one randomized control study, and it basically was comparing it to thrombolytics with an intermediate risk PE, not with submassives or massives. So that data was kind of okay with that group, but that's the only one that was even randomized. All the other ones are pretty much just case series of 20s and 30s of patients who have had these done. So it's unclear what that real role is in this, despite the fact that of the case series, they have had some reasonable data. Now, surgery, we'll talk about this. This is the Trendelenburg procedure. It is done on bypass without a cross clamp. And as you can see here, this is just cannulating IVC SVC. You don't have to just cannulate the IVC SVC. You can cannulate the right atrium. One cannula here. We open up the PA and extract the clot. You can use a Fogarty catheter. You go in and take a balloon and pull the clot out. The other trick is to open up the lung fields, reach back down there, give a breath, and then squeeze the lungs. By squeezing it, the blood actually comes back at you, and you can bring some blood back up towards you. And then to get to the right side, you push the aorta to the side, SVC to the side, go to the RPA, and extract, and then go down on that side as well. And then to close up, basically, you close up the RPA, you close up the main PA, and you're done. The operation doesn't take very, very long. Usually it takes about an hour and a half or so, skin to skin. Bleeding is a problem. A lot of these patients that we are taking to the OR have already received some other lytic therapy, and it becomes salvage. And these are patients who bleed quite a bit, unfortunately. This is a patient that many of you guys have seen this when we first extracted this. This one came out of a guy who was actually on the floor crumping, who was, quote unquote, successfully treated with a catheter-directed therapy. So I took him to the OR and pulled that out after what was considered a successful thing. And all of us have pictures of several of these that we've extracted. So it's rather dramatic. And these people, when they tolerate the surgery, which most do well. So how do we compare? What about this? Are there any comparisons on how we do and what should be the approach? So this was looking at the registry in New York, where they looked at patients who were treated with surgical versus thrombolytics. And again, this is not a head-to-head, this is just a registry. And so if you look at the outcomes, mortality and recurrent PE and recurrent DVT were really no different. Well, that shouldn't surprise you. We're really talking about the therapy as opposed to prevention of further disease. So that wasn't that different. There was a higher incidence of reoperation or reintervention with thrombolysis, which was statistically significant, and major bleeds, which was higher in surgery, but stroke, which was higher in thrombolytics. And here is graphically what it looks like. The incidence of recurrent pulmonary embolism is about the same. The incidence of recurrent embolism required readmission was tending to track with a slight improvement in surgery over thrombolytics, but at least statistically did not reach significance there. And then the overall survival is about the same. So then, well, what about surgery versus catheter-directed therapies? So there's no head-to-head for that. So this is a meta-analysis of 41 papers looking at the two. And to sum up, it's really hard to compare because they're very two different populations that they were really talking about. They both had satisfactory outcomes, but 21% of the patients who went to surgery had CPR, either ongoing or prior to, whereas 4% in the catheter-directed therapy. And if you looked at the people who had CPR, whether it was in catheter-directed therapy or surgery, there was still a 46% mortality in both arms. So if you have CPR, and this is really prior to a lot of ECMO being utilized routinely, the outcomes were significantly skewed. So a lot of the deaths in surgery were basically because of this particular data. But as they analyzed it, they thought there was an advantage to surgery, one, because it was more complete, and potentially though, and specifically for those who may need a mechanical circulatory support with severe RV failure, and for certainly larger and central embolic burden. And their thoughts were that catheter-directed therapy was really for people who couldn't take surgery for whatever reason and had more peripheral disease. So there was also an 8% failure rate requiring reintervention on the catheter-directed therapy and none in the surgical arm. So we have this is our algorithm at Abbott, and it's on your app if you want to look at it. And I'm not going to go through it, but bottom line is we somewhat are focused on anticoagulation with surgery as more of a salvage approach to it. This is a point of discussion for us because there is not a whole lot of data to compel us to do more surgery, but the data suggests that surgery has a higher role. And a lot of places actually don't do this procedure, interestingly, even though technically it's not very difficult because the programs have not been set up that way. People think of PE surgery as a surgery for chronic thromboembolic disease, which I'm going to go into in a bit, which is a totally different animal from acute embolic disease. This is an easy operation. Surgery for chronic thromboembolism is a totally different animal. And people who aren't really understanding of this equate them. So what is our data? Our data over the last 2 years is not complete, and I give Roman Mohamed full marks for really organizing this, developing this, and getting us all involved in this so that we can move the needle with us. And Roman gave me this data. So if you look at, in 2018, we had 372 patients with PE that was treated in this hospital. It's quite a large number if you think about it. I didn't realize how large that number was. 384 in the past year. And if you look at, we have this PE response team activation that occurs, which if you hit a certain threshold, which is the submassives and massives, they get, there's a call out, the ICU gets involved, surgeons get involved with the massives, interventionalists get involved with the submassives. And then we go through the algorithms and determine the direction or the path of these patients. And of those, you can see, almost 40% had an ICU stay. Of the 16 catheter-directed interventions, we didn't have a great survival on that. We had 2 PE arrests during the procedure, as well as hemorrhage. In 2018, we only had 3 that went surgical embolectomy, 2 out of 3 survived, and 4 received ECMO. In the past year, the data is not all there yet. We don't have all of our patients analyzed yet, but 35% ICU stay, 9 had catheter-directed interventions, don't have the outcomes yet. Surgery, we had 7, only 3 survived of the 7, but 3 of the patients also had presenting EFs of 10 to 15%, and 1 was a salvage after a failed catheter-directed therapy as well as TPA. So those were our 4 deaths. So anyway, we're trying to move the needle and using this data to kind of guide how we should be in our institution approaching this problem. What about the question of an IVC filter? The bottom line is it used to be very vogue to anybody who had this would get an IVC filter. The data really is not supportive of that. And IVC filters are really relegated to people who still have ongoing clot burden or those who are not able to take anticoagulation for whatever reason. And retrievable filters are preferred because there is a high complication rate of migration and perforation, et cetera, et cetera. So IVCs are really not a good preventative therapeutic options. What about follow-up? How should we treat these patients? If this is the first time, this is the data from the recent European guidelines that came out in 2019, is that to use oral anticoagulants for 3 months. You can consider stopping them, but most will keep them. The data kind of in that second group of with whom anticoagulation should be considered is pretty much everybody. They said if you can tolerate it, maybe you should go longer on it. The evidence is kind of okay, but more and more people are anticoagulating these people longer. Particularly, I mean, everything's risk benefit. What is the risk of your therapy, which is anticoagulation, versus the risk of having PE disease? And as we're having these other vitamin K oral anticoagulants that appear to be safer for the population, extending the therapy with with those, the Eliquises, et cetera, appear to be gaining traction because it seems like that risk benefit exists. I did not really talk about pregnancy. Pregnancy is a huge problem for pulmonary embolic disease for two different kinds. Number one, they can have regular PEs from clots, and then the treatment for that is challenging. The idea is to try to do a therapy that preserves the fetus and avoids placental transmission of anticoagulants. So low molecular weight heparin from the Paranox are utilized for those patients. Surgery and thrombolysis both have very, very high mortality, fetal mortality, in about a 20% for those patients. And embolic disease from amniotic fluid is a totally different topic, which I know very little or nothing about. So I'm not going to really touch that. So this is at least the guidelines are changing in terms of the amount of anticoagulation for follow-up. And how do people do? What is the prognosis for it? Well, there's a relatively large study where they looked at 1,000 patients, and there was a 32% mortality over 5 years. And of those, 5% were due to recurrent PEs. 30% was really caused by other cardiovascular issues, not surprisingly, that can contribute to death. And 64% were non-cardiovascular causes, but also probably predisposing for you to get PEs anyway, cancers, et cetera, et cetera. So how do we follow up? Well, without going through this chart in detail, the idea is that these people are still at risk for developing chronic disease. So there should be still some level of monitoring over time, because after anticoagulation, do they have any symptoms? If they have any symptoms, they should be worked up for either other obstructive causes or other embolic causes of shortness of breath to develop CTEPH, or other non-vascular causes of shortness of breath. So I'm going to briefly finish up with talking about CTEPH, which is the chronic thromboembolic pulmonary hypertension. It's a totally different entity. This is the chronic clotting and then buildup of laminar fibrosis within the lungs. This is not fresh clot. It does occur with people who have PEs. The data on that is being gathered as to what is the incidence of it afterwards. It's very variable in terms of what is published. They range from 0.1 to 9% within 2 years, depending on which patients, which papers you look at. We think there's probably some referral bias for some of the higher numbers for it. But there's a registry in Switzerland and another one in Europe, and I'm blanking on it, that is looking at all of their PE patients over time and see what the incidence of developing it based on their therapeutic approach. And it seems to be quite low, at least within 2 years, about 1%. At about 5 years, it gets up to about 5%. So it does start to creep up over time. And as you can see on the picture on the right, there's really a scar tissue that's forming in the vascular bed. So what are the risk factors for it? Large PEs and hypercoagulable states. We don't have any data as to how the initial approach to the treatment of this disease, where the sequela is. So we do not know yet whether or not doing regular anticoagulation, thrombolysis, CDIs, or surgery, which one leads to this more often than not. We don't have enough data to say that is that doing one or another is better. Conceptually, one thinks that the more thorough you are up front in terms of extracting the clot should lead to it, but we don't have enough data to confirm that. And we also don't, partly because we also are not following these people up with regularity to understand what their recurrent burden is. You can clear it up first and get perfect result, but if we're not anticoagulating or monitoring them for ongoing subsequent pulmonary embolic events, then they can still develop this disease anyway. So TBD in terms of what that is. Now, how is the surgery performed? Totally different animal. You are on cardiopulmonary bypass, but you're doing endarterectomies for the entire pulmonary tree. And that is a very, very difficult operation. That is done with cross clamp, hypothermia, and arrest. So to work in that, you basically stop the circulation. You cool down to 18 degrees centigrade. You stop the circulation. You open up the PA, and then you clean out portions of it. And then you go back on for a short period of time to give the heart and the brain a drink. and then you do it again. And you keep doing it until you get this all out. And for circ arrest times, and the ones that I've scrubbed in on, usually are about an hour and a half of total aggregate circ arrest time that are in kind of 10-minute groups. And you're slowly doing endarterectomies around each of the pulmonary vasculature, going all the way down into the segmentals and subsegmentals. It takes a long time. It's very tedious. ECMO is very common after these patients, for these patients. But it can be very, very rewarding too in the patients. And this is what it looks like when you take this all out. This was not the case. I was on a case when I was down in Brazil, and we were in there for about 2.5 hours digging this stuff out, and it looked very similar to that at the end of the day. So that is, as you can understand, there's very little blood and thrombus in it. This is basically just fibrosis, and cleaning this out works. Now, there are the bronchial ballooning is also a vascular ballooning of these blood vessels to open up proximal disease is also utilized with some success, and they're often done with in sequence. But this is still the kind of accepted gold standard for it. So I'm going to kind of wind down and say my final thoughts on this is that this is clearly a problem that is a growing population for us. We as a coordinary care center are going to be getting more of these kind of as the cardiogenic shock ECMO patients, and with more circulatory collapse. The question that we are trying to grapple with is, should we be changing our approach to it? The data is encouraging us to use surgery earlier than some of these other therapies. But again, that there is obviously some inertial components of that may be difficult to change. What really is the role of catheter-based interventions? The current data is kind of met at best in terms of its efficacy and durability. But that doesn't mean that some of the newer approaches to it with the suction catheters may be better in select populations. And the other question programmatically from our institution is, should we be moving towards CTEPH as another additional therapeutic option for our patients? There are very few CTEPH programs in the country. There are 2 in Boston that I know of, 1 in New York. In the Midwest, there used to be one down at Mayo. Their surgeon who did that is no longer there. They do bronchial artery ballooning down there, but they don't really have a robust CTEPH program. And then the other ones are 2 out in the West Coast that are very well known. And so there is a potential opportunity for looking at that, but it is a very specialized therapeutic problem, and whether or not strategically this is something that we want to go into is something for discussion. I think throw that out. So I'll stop there and take any questions.
And as you look at the catheter-based stuff, it really there's a signal for alarm there.
Yeah.
I just wonder if Roman and yourself have had a chance to think about that. My first reaction was maybe patients ought to go on ECMO before a catheter-based therapy, because I think the death rate, did I read the slide correctly? The death rate was 70%.
Right, in our patients last year. We don't have this year's. It was, and I want to say that really around 2017, beginning of 2018, we kind of reintroduced ourselves like, hey, yes, we kind of do this. This is not, and we're happy to jump in on it. So prior to that, I think there was a reluctance to even engage the surgeons in this, and so maybe we've just moved the patient's graveyards from one side to the other side of the graveyard. But the idea is that we do have other therapies that we can offer, and maybe we should be moving it. I agree with you. I think our data has been kind of not great. The national data is unclear right now for catheter-based interventions. Yeah, Brandon.
Just to piggyback on that, I thought the catheter-based data was very interesting. Maybe it's a patient selection thing, because I mean, just my experience with catheter-based low-dose lytics, so the 24 hours of 1 milligram an hour sort of thing. We did that at the NIH and in DC and got great results, but it wasn't for patients with massive.
Right.
You know, we're picking out the patients with submassive, and the idea there is to prevent down the road sequelae that you're talking about, like pulmonary hypertension down the road, you know, impaired exercise tolerance down the road. And, you know, and this is anecdotally for me, but very, very limited morbidity associated with it. We actually would give it even just with a peripheral IV and not put a line in, and that way there's less bleeding.
We have the same results here,
Yeah.
but they were not the submassive.
Right.
And it's the same protocol that you're talking about. There's one thing about CT. You made mention that had you gotten a CT, you would have had a higher suspicion for a CTEPH. And I think that's very unlikely. The spatial resolution is not very good. And that's where invasive angiography is much more helpful in identifying who has webs and who doesn't. It can be very difficult on the CT.
Well, that might have been a lost cause at the get-go,
Yeah.
but
Yeah.
we were just thinking about what could we have done differently in that. And we actually got him through the operation. You know, we struggled with the vent, but unfortunately, it was actually his prolonged downtime that led to his particular demise. It just would have saved him an operation as opposed to, you know, we might have well just sat on the guy.
I have a question. If you got PE and came to Abbott with tachycardia, through RV strain, the sign on the RV that I never remember the name of.
McConnell sign.
Thank you. And you were normotensive.
Yeah.
And you had a central PE. What would you want to have?
Me?
Yes.
I'd want. Maybe I'm out there though. I wouldn't want my chest open. But that's me. But you know, 90+% of the population does not. Will not.
Didn't trade this question for something else.
It's just because you know we're there. We know the recovery and how quick it can be.
I would ask for the same, but
Yeah.
we're biased.
Yeah, we are biased. We're definitely biased.
It looks like on your slide, the amount of surgery is bumping up from 2018 to 2019. Is that because
It
there's
is.
growing awareness?
I think that's part of it, but it's still, you know, we're still at this point salvage as opposed to, you know, there are very few that are non-salvage right now, right? People have tried other things prior to calling us. We've had the successes that we've had with those who they never even tried a CDI or they never tried thrombolytics because, you know, 2 of them were relatively proximate to brain surgery or something else. And so we took them and they walked out of the hospital in 5 days. So that's what we want. But unfortunately, that's not always what we get. Most people will, even in our institution, they'll try a thrombolytic even on the ECMO before we get them. And then it's only the failure ones that we're taking, and those are the ones who we're struggling with.
Thank you.